Hi friends, today our topic is antidepressants. Let's start with question 1. Question number 1 is regarding endogenous depression, whether it is due to deficiency of acetylcholine, adrenaline, noradrenaline 5-HT and dopamine, or due to histamine deficiency. So endogenous depression, it's mostly because of the deficiency of most of the common neurotransmitters like norepinephrine, 5-hydroxytryptamine and dopamine. Question number 2 is regarding SSRI, selective serotonin reuptake inhibitors, fluoxetine, paroxetine. These are preferred over tricyclic antidepressants because of negligible anticholinergic side effects, less cardiovascular side effects, less sedation, or all. Basically, SSRI are having very less side effects because of their negligible action on muscarinic receptors, less action on alpha adrenoreceptors, and less action on histamine receptors. So that's why they don't have anticholinergic side effects, they don't have cardiovascular side effects, they are less sedative. So all of the above options are correct. Question number 3 is regarding escitalopram. It's preferred over citalopram as it is more potent, it's safer, it's having less drug interactions, or all the above options are correct. Escitalopram is basically S enantiomer of citalopram, and the difference between the two is that escitalopram is more potent. It's almost 1,000 times more potent than citalopram. It's having it's safer and its drug interactions are very less. So all of the above options are correct. Question number 4 is an active metabolite of which SSRI prolongs the duration of action of drug to 7 to 10 days. Is it fluoxetine? Is it paroxetine, escitalopram, or sertraline? Basically, all the below mentioned drugs are selective serotonin reuptake inhibitors. We have to find the drug which produces active metabolite, and because of the active metabolite, its duration of action is prolonged. So it's fluoxetine. Its active metabolite is norfluoxetine, and it's having duration of action of almost 7 to 10 days. Question 5. SSRI acting by increasing serotonin levels in synapse leads to decrease in brain-derived neurotropic factor, increase in brain-derived neurotropic factor, increase in acetylcholine, or all the above options are correct. Basically, as we know that in depression, there occurs tropic changes in certain parts of the brain, and this is because of loss of neurotropic factor. So this drug SSRI will increase brain-derived neurotropic factor. As this serotonin levels in synapse increases, it acts on the postsynaptic serotonin receptors. This enhances transcription of brain-derived neurotropic factor. Tricyclic antidepressants act by inhibiting reuptake of dopamine, norepinephrine and 5-HT, norepinephrine and histamine, or all of the above options are correct. So tricyclic antidepressants, they act on two transporters. One is norepinephrine transporter and another is serotonin transporter. So it inhibits reuptake by acting on these transporters. So there is accumulation of norepinephrine and 5-HT in the synapse, and this is the main mechanism of action of tricyclic antidepressant. So it will inhibit reuptake of norepinephrine and 5-HT. Side effects of TCA are postural hypertension and tachycardia, constipation, blurred vision, urinary retention, or all of the above options are correct. Tricyclic antidepressants, besides acting on serotonin and noradrenergic receptors, they act on histamine receptors also, so they have H1 blocking action, and because of this they can cause sedation, confusion also. They have alpha 1 adrenergic blocking action, and because of that they can cause postural hypotension and tachycardia. And they have a muscarinic blocking action also. This is the reason why they can cause constipation, dryness of mouth, blurred vision, urinary retention. So all of the above options are correct. Acute toxicity with tricyclic antidepressants is managed by administering atropine, sodium bicarbonate, amitriptyline, or all of the above options are correct. So as we know, tricyclic antidepressants have low safety margin, and there are chances of acute toxicity with TCA only as their cost is, as they are less expensive. That is the only benefit, they are still in use. Otherwise, if we will compare it with SSRI, SSRI is better option. So how to manage TCA if the patient gets toxicity with TCA? With tricyclic antidepressant toxicity, patient will have acidosis. So we have to neutralize that acidic pH. So we will give sodium bicarbonate. Sodium bicarbonate is drug of choice in TCA poisoning. And secondly, it will provide sodium also. As we know, with TCA, they will block alpha adrenoreceptors. Because of blockade, they cause postural hypotension and reflex tachycardia. So by providing sodium, it will also improve blood pressure. So this is drug of choice. Plus we have to take care of convulsions. If the patient is convulsing, we have to give anticonvulsants like diazepam or phenytoin, and for arrhythmias we have to give lignocaine or propranolol we can give, and other supportive measures like IV fluids, respiratory support is needed. Selective serotonin norepinephrine reuptake inhibitors, they are different from tricyclic antidepressants in having action on serotonin transporter and norepinephrine transporter, action on presynaptic neurons, or they don't have any anticholinergic, alpha blocking, or antihistaminic effects, or all of the above options are correct. So basically, selective serotonin norepinephrine inhibitors, these are like venlafaxine, desvenlafaxine, milnacipran. So these drugs exclusively act on two transporters like serotonin and norepinephrine transporter, which are present in presynaptic neurons. But so they don't have any anticholinergic, alpha blocking, or antihistaminic effects. So option C, that is no anticholinergic, no alpha blocking or antihistaminic effects are there with SNRI. So TCA, if we will see, they have a wide range of action, like they will act on histamine receptors, they will act on alpha adrenoreceptors, they will act on muscarinic receptors, and because of action on these receptors they have many side effects also. So SNRI is different from TCA in having exclusively action on SERT and NET, that is serotonin transporter, and norepinephrine transporter. 5-HT antagonists acting as antidepressants are venlafaxine, desvenlafaxine, amoxapine, mirtazapine, trazodone, nefazodone, or fluoxetine. So venlafaxine, desvenlafaxine, we know it acts on SERT and NET transporter, that is, it is selective serotonin norepinephrine reuptake inhibitor. Amoxapine and mirtazapine, these are atypical antidepressants. Fluoxetine is selective serotonin reuptake inhibitor. Only trazodone and nefazodone is left. So these are 5-HT2 antagonists. A typical antidepressant enhancing release of 5-HT norepinephrine, causing increase in appetite and weight gain and sedation, as its side effect is it amoxapine, bupropion, mirtazapine, and minesarin. All these are atypical antidepressants, so we have to find out the drug which acts on 5-HT and noradrenaline receptors, and thereby increases weight as well as increases appetite, and sedation is its main side effect. So it is methazapine. This is the drug which acts on alpha adrenergic and serotonergic receptors, increases the levels of 5-HT and noradrenaline in synaptic cleft, and also leads to increase in appetite, thereby leading weight gain. Only sedation is the main side effect of methazapine, and methazapine we can start the dosage of 7.5 milligrams. Then according to the patient's response, we can increase the dose, and maximum dose is almost up to 45 milligrams per day we can give. A typical antidepressant with a weak dopamine reuptake inhibitor action, preferred for depression with anxiety, and also helps in smoking cessation is it amoxapine, is it bupropion, is it methazapine, or is it mianserin? So basically it is bupropion. They have weak dopamine reuptake inhibitor property also, thereby increases the dopamine levels in synaptic cleft, and it's also preferred for depression with anxiety, and it has a role in smoking cessation also. It's given along with the nicotine patch, so bupropion is the correct option. Match the following drugs with their side effects: mianserin, methazapine, trazodone, and nefazodone. So mianserin causes blood dyscrasias. Methazapine, it causes weight gain and sedation. Trazodone causes priapism, and nefazodone causes hepatotoxicity. A patient developed sudden rise in blood pressure on taking food rich in tyramine, cheese, fish. Medical history revealed that he was taking some antidepressants. Which antidepressant do you suspect he was on? Tricyclic antidepressants, monoamine oxidase inhibitors, SSRI, or SNRIs. So there is rise in blood pressure after taking food rich in tyramine, and it was revealed that patient was on antidepressants. So it's most probably monoamine oxidase inhibitors, because we know monoamine oxidase inhibitors inhibit monoamine oxidase, which is an enzyme present in our body, and normally this enzyme degrades monoamines like noradrenaline, dopamine, serotonin, and tyramine. So patient took tyramine rich food, and tyramine is normally metabolized by monoamine oxidase A enzyme, and if patient is on inhibitor of this monoamine oxidase, so tyramine will skip metabolism, so rise in tyramine levels will lead to displacement of noradrenaline from nerve endings, and this will lead to hypertension, and hypertensive crisis can be there. This is the slide showing monoamine oxidase A and B enzymes in our body. Monoamine oxidase A normally metabolizes serotonin, dopamine, norepinephrine, epinephrine, and tyramine, and monoamine oxidase B metabolizes dopamine. And we know monoamine oxidase B inhibitors are given where we need to increase the levels of dopamine, like in Parkinsonism. So selegiline is one of the MAOB inhibitor which is given in Parkinsonism to increase the dopamine levels. Question 15 is regarding serotonin syndrome. Which combination of drugs once given can cause serotonin syndrome? Is it carbidopa, benserazide, methotrexate, folinic acid, MAO inhibitors, SSRI, sulfamethoxazole, and trimethoprim combination? First of all, what is serotonin syndrome? Serotonin syndrome occurs when there is significant increase in serotonin levels in the synapses, and this can happen if we give the drugs which reduces the reuptake of serotonin and which will inhibit its metabolism. So raised serotonin can lead to hyperthermia, like fever will be there, diarrhea will be there will be sweating, muscle rigidity, aggressive behavior, seizures, and patient can even go into coma. So the combination which will increase the serotonin levels in the body is monoamine oxidase inhibitors and SSRI, because monoamine oxidase inhibitors will inhibit metabolism of serotonin and SSRI will inhibit its reuptake. So both will increase serotonin to a significant level that patient can get serotonin syndrome. So such combinations we have to avoid. We should not give patients of depression such combinations. Question 16. Non-selective irreversible monoamine oxidase inhibitors are not preferred due to long-lasting action and many side effects, hypertensive crisis with tyramine-rich food, serotonin syndrome with SSRI, or all of the above options are correct. So basically non-selective irreversible monoamine oxidase inhibitors are isocarboxazid, phenelzine, trianylcypromine, and these inhibit both monoamine oxidase A as well as B. So there is chance of increase in serotonin and norepinephrine and dopamine levels to a significant level, and there are too many side effects, too many drug interactions, and these inhibitors also interact with food like tyramine rich food. So this can lead to hypertensive crisis if given with tyramine rich food. It can lead to serotonin syndrome if given with SSRI. So mostly because of these things, these monoamine oxidase inhibitors are not preferred. Question number 17 is regarding moclobemide. Is it a selective serotonin reuptake inhibitor? Is it a reversible selective monoamine oxidase A inhibitor, reversible selective monoamine oxidase B inhibitor, or non-selective monoamine oxidase inhibitor? So it is a reversible selective monoamine oxidase A inhibitor, and it's short acting, and monoamine oxidase activity recovers within 1 to 2 days after stopping the drug. And it has an advantage that it is not sedative, it does not produce cardiovascular or anticholinergic side effects, and no significant drug interactions are there. Only its adverse effects are nausea, insomnia, headache it can cause, and it's also useful in anxiety related mood disorders. Next question, the response, like in the form of improvement after starting antidepressants in a patient with endogenous depression, will be seen after 2 to 3 days of treatment, after 2 to 3 weeks of treatment, or 5 days after treatment, or 1 month of treatment. So most of the antidepressants response you will see after 2 to 3 weeks of treatment. Question 19 is regarding phenelzine. Phenelzine is selective serotonin reuptake inhibitor, reversible selective monoamine oxidase A inhibitor, reversible selective monoamine oxidase B inhibitor, or non-selective monoamine oxidase inhibitor. So phenelzine, which is not usually recommended because of its many side effects, many drug and food interactions, as it is non-selective monoamine oxidase inhibitor. It inhibits both enzymes monoamine oxidase A and B, thereby causing significant rise in monoamines, and because of that there are chances of hypertensive crisis, serotonin syndrome. So that's why it's not preferred. So it's non-selective monoamine oxidase inhibitor. So question number 20, our last question. To minimize side effects of tricyclic antidepressants, drugs should be started with a high dose and then taper, started with a low dose and gradually increase the dose, no change in dose, none of above. So drug should be started with a low dose, and then gradually we can increase the dose of the drug depending upon the patient's response. So this was all. Thank you.